Now, hi, it's Dr. Bob Dannenhoffer. I'm the Public Health Officer for Douglas County on May 15th, and we're talking about lots of things tonight about COVID and related topics. I'm wearing my balaclava. This one nicely matches the shirt, but I'm going to take it down for those who lip read. And it's very interesting. You'll remember last time we did one of those masks with the lip reading clear plastic in the middle, and there was a great story in NPR this week about people who are making those and how people who lip read are so appreciative of providers who have one around. So our briefing for today, it's still pretty grim in the rest of the world here. 4.6 million cases and over 300,000 deaths in the world. In the U.S., we're at 1.4 million cases and 88,000 deaths. Now, 88,000 deaths is a lot of deaths. It's more deaths than in all the wars since World War II. In the rest of the world, big outbreaks in Russia and Brazil, with 10,000 or more cases a day in those two areas. And that's a big concern because we think both of those areas have struggling healthcare systems. In the U.S., in the cases we're seeing here, Oregon is still doing great. We still have the 5th lowest attack rate in the country, and Southern Oregon has a much lower attack rate than the rest of the state. So Southern Oregon has a very low attack rate. We're still at 24 cases. I know if you looked at OHA today, it's at 25. But that was a transposition that somebody outside of Douglas County made, where they switched somebody's first and last name and created a new case when really it was a test for an old case. So don't worry about that. We really still are at 24. We're now on the 25th day of 24. And so we've not really had lots of new cases. And so we're doing great here in Douglas County. And because of that, Douglas County was one of those first counties that was allowed to reopen. So we're now in phase 1 of reopening. That doesn't change everything. It changes a few things. One is it allows some in-restaurant seating for people there, some in-bar seating for people who want to go to a bar. It allows people to get their hair done, and what I've heard, lots of sighs of relief from people who are getting shaggy. And it allows gyms to be open with very strict guidelines. So I think we're starting to loosen up here. We'll see what happens. Our concern is that if we loosen up too much and people get a lot of disease, we'll see another spike. But for right now, things are looking pretty good. So I'd encourage people to follow the rules. And the rules still say you're supposed to socially distance. You're supposed to stay home if you're in a high-risk group. You're supposed to stay home if you can. So if you can telework or do things electronically, you should. And we should still wear a mask. So the masks are great to be wearing if you're in public or if you can't do social distancing. Here, we've established our social distancing, so the mask is not necessary. I also wanted to clarify something last time. They said, well, what about the Surgeon General and masks? And I did find that clip, and now I get it. So early on in this, we had talked about using masks to prevent you from getting the disease or prevent me from getting the disease. And now, as you'll remember, even I said, well, masks to prevent you from getting the disease are kind of a mixed bag for a couple reasons. One is that these masks don't work particularly well to prevent droplets from coming in. And the other problem is that if you use a mask and you're not used to using a mask, you do a lot of face touching. And face touching, we think, is as dangerous as anything. So that was why early on we were a little bit confused about whether you should use masks. But then what we found from data that came from the U.S. and other countries is that people were most contagious before they had any symptoms. So if you tell people to stay home when you're sick, that works great. But if you can be contagious before you have symptoms, that's really problematic because you can spread the disease unknowingly. And when we found that out, then that was a recommendation that the CDC and now others have done, that you should wear a mask when you're out in public, or face covering when out in public. But again, it's not to prevent me from getting the disease from others. It's to prevent me from giving the disease to others. And that's why the Surgeon General had said that early on. And if you look what he says now, I think it's all the same. So there was a little confusion in the beginning because I think we didn't early on recognize the pre-symptomatic transmission. But the pre-symptomatic and mildly symptomatic transmission is one of the most striking things about this disease. So one of the case reports that came out just in the last few weeks was about a choir practice in the state of Washington. So this was a choir, about 60 people in the choir, and they spent 2.5 hours vigorously singing and being close to each other as you would be in a choir. Well, there was one person there who was mildly ill, not so sick that they had to drag themselves there, but they were sick with cough and symptoms. They gave it to 52 other people, and a number of them died. So that shows just how contagious this is in a closed area. Again, what we're seeing is multiple stories of how this is spreading at choir practice, how this spreads at a funeral, how this spreads at a birthday party, how this spreads at a cocktail party. And again, these things have a couple of characteristics. One is that they're all indoors. The other characteristic is extended period of time. So we don't have any cases where people are together for just 3 minutes and they got it. It's when they're together for the extended period of time. And the other thing we're seeing is animated discussion and singing. So singing in the choir, animated discussion like you might have at a funeral are the things that really seem to be the risk factors here. So still out there, it's still quite dangerous. And wear your masks, socially distance, and enjoy reopening. So the question Bob asks, can we have garage sales under phase 1? I think so. So I think if you can ensure social distancing and there are less than 25 there at a time, I think you can. So Heather says, as a teacher, what do you anticipate the fall looking like with kids returning to school? And I don't know the answer to this. We had a long discussion with the superintendents over the last couple of days and then some long email things. I don't really know. If we say it's going to be like childcare, that would suggest that we cohort kids. So the childcare recommendations are that you cohort kids, and the best way to think of it is a team of 12. Only 10 can be on the field at any time, but it needs to be the same 12 around. I could see certainly something like that for the K-6, in which case you may only go half days or 3 days a week or whatever. So I'm not sure how that's going to work, but I would see smaller classes, I would see cohorting, and I would see the getting rid of the gathering things, which would be like lunchtime and assemblies. So recommendations for play dates during phase 1, Florence asks. Well, again, the recommendation is to limit gatherings to 10 or less. I don't think play dates are specifically outlawed, but again, play dates increase the number of contacts. So the way I think about this as an epidemiologist is that if you had a case, how many people would we have to track down and quarantine? So I've been incredibly careful about myself in the last month. And at any time in this last month, if I came up with a disease and they asked me, well, Bob, how many contacts did you have? Let's go through them. And what I would say is I've had a single contact, which is my wife. Don't think we can eliminate that. So I would have had a single contact along the way. I have not had 15 minutes within 6 feet of anybody else in that month's time. And so I would be easy to do. What I worry about, though, is that if you have a play date with this kid and then you have a play date with another kid and whatever, it's all those people to track down. So I think play dates, they're not specifically talked about in phase 1. Again, you want to limit your contacts. So Betsy says, how much random testing is done to check the spread? And so random testing to check the spread has been found not to be particularly useful. So there are a number of random studies that have been done in Oregon. The most obvious of one is the one in Corvallis, and I think the data there showed that nobody had it, or very few people had it. So random testing has not shown to be particularly useful in an area where the incidence is low. I think far and away the thing that's been suggested is that you test everybody no matter how mildly symptomatic they are, and that's probably the best strategy. Because to test everyone, as they're doing in Wuhan, even in Wuhan, where there's a very low case incidence, they found to be nearly impossible to do. But testing everybody, no matter how mildly symptomatic they are, does seem to be the best strategy. So Brandy says, many people are still claiming that they likely had COVID. Are the antibody tests reflecting that? And the answer is no. We've had a lot more antibody tests over the last few weeks. We only have 4 positives, and those 4 positives are very clear who they were. And so we've not seen any of those people said, I must have had it in February or March, come up with a positive test. I've encouraged dozens of people to get it, and yet we haven't seen a positive yet. So they may be out there, but there must not be particularly many. So one of the questions we had last time was the case fatality rate and the infection fatality rate. This is going to be a little boring here, so if you don't want to do this, it's time to get a soda pop or a beer, and then we'll talk about it. So the case fatality rate is, if you know the number of cases that you've said you have of COVID and the number of deaths, what is your case fatality rate? So the case fatality rate in the U.S. now, again, we have 88,000 deaths and 1.4 million cases. So our case fatality rate is about 1.7 or 1.8%. In the world, with 4.6 million cases and 300,000 deaths, the world case fatality rate is 6%. The case fatality rates are very dependent upon finding cases. So when I've been concerned that the case fatality rate in the world is so high, is that I'm fearful that we've not found many of the cases in the world. Now, I think the U.S. has done a little bit better job in that, having a case fatality rate of 1.7%. If you look, for example, in China, the case fatality rate early on was about 3.4% and is now down to about 2%. In Singapore, which has probably done the most testing of anyone in the world, their case fatality rate is down to 0.1%. So you see a huge range from 0.1% to, in the world now, 6.6%, and in some countries as much as 15%, which means that they're not finding most of their cases. But the question about infection mortality rate was, if you knew how many people were infected, what would be the fatality rate there? And I think most people have asked that question because in the end they come to, well, if you knew the infection fatality rate was only 0.1%, well, what would you have done the same things you did now? And so I think there are two fallacies here. One is there's no one who's suggesting that the infection fatality rate really in the end is going to be 0.1%. So how would we know this? Well, we've got a few good studies. So in the Diamond Princess, where they tested everyone, the infection fatality rate was 1.8%. On the Ruby Princess, another ship where they tested almost everyone, the infection fatality rate was 3%. In the Teddy Roosevelt, this aircraft carrier, the infection rate was 0.1%. But again, to be on an aircraft carrier, you have to be young and healthy. So that was 0.1%. In the military overall, where they've done a lot of testing, their rate is 0.3%. And then in Gangelt, Germany, which is where there's this little town on the Belgian border. They had this Bavarian festival. Everybody drank a lot of beer, as I guess they do. And there was one really gregarious bartender who gave it to a bunch of people. And so they had a big outbreak there. About 14% of the people in that area had antibodies, so had infection. And they calculated their infection fatality rate of 0.37%. And in the typical German precision, I read this long paper today that said, well, maybe it was 0.38% or 0.36%. But in the end, I think about 0.4%. Now, if you look in the U.S., in Brooklyn and the Bronx, their infection fatality rate was about 1.2%. So it goes anywhere here now from 0.1% on the Teddy Roosevelt and in Singapore to 1.2% in Brooklyn and the Bronx. So what in the end is the infection fatality rate going to be? It's probably, but age adjusted, it's probably going to be 0.5%, which means that if you found every infection, it would be 0.5%. Well, let's think about that. So would we have done anything different if I knew, I could just tell from the beginning that the infection fatality rate was 0.5%, so 0.5%, one person in 200? Well, let's think about what that would have meant in Douglas County. So if we would say that everybody would get the infection, and we think almost everybody would get the infection over 6 to 9 months, that means it'd be 80,000 cases of the disease in Douglas County. It's a lot, right? And if it was 0.5%, so 1% of 80,800, it would be 400 deaths. And for every death, there are 20 hospitalizations. So could we really have dealt with that many 8,000 hospitalizations? The answer is absolutely not. So if we let just this thing burn through, at some point the hospital said, look, we've run out of equipment, and a lot of our people are sick, we're just going to need to close down except for catastrophes. What would that have done to society? I mean, the orders to close down certainly hurt businesses. But if the hospital had a sign on, we're closed, we've run out of equipment, and all the hospitals had signs said, we're closed, we've run out of equipment, what would that have done to society? So even now, in perfect retrospect, I think the idea that you would have just let this thing burn through society is horrific. I mean, to expect that many deaths, to expect that much social turmoil just makes no sense at all. So I'm sure we're going to get a million comments that my math is wrong, that we wouldn't have run out of stuff, but if anybody knows better, I'd be willing to take this on. Okay, so are nail salons open now? Judy asks. And the answer is yes. I probably need to get my nails done. Nail salons are open. There are rules, and the rules are that everybody needs to wear a mask. There's not a lot of waiting. We try not to have people delay, that they want people to keep appointments so that if one or the other person is, either the client or the nail person is infected, that we can contact them and quarantine the people. So Deborah asks, how is it decided when businesses are going to be opened? So there are two questions. One is when we hit the phasing. So if you looked at the president's plan, they had these gates that you needed to go through about declining cases and adequate PPE and adequate public health to do it. So we look at the gates. This first gate was May the 15th. The next time we're going to look is in about 3 weeks. And you still need to be eligible to reopen. And then the rules about the businesses were made by groups from the businesses. So for example, I don't know exactly who did the nail one, but I do know who did the wine one. And so, Douglas County's got a great wine industry. And so there are a number of people from the wine industry in Douglas County that were involved in making recommendations for opening. For the gyms, I know the YMCA was involved in those decisions for opening there. And so the people who knew about this made logical rules that would work for their industry. And so then when the gating criteria was made and the medical advisory panel was involved in that, and then when the sector guidance came in from the sectors, that's how it happened. So you said, have we asked the people who tested negative to go get an antibody test to see if the first test was incorrect? We've not asked all of them, but all of my patients and anybody who's asked us, we've asked them to do that so we can see. Because that would be one of the interesting things to know. So if you really had a highly suspect case and were negative on the antibody test, maybe you were positive and you should get an antibody test. So all the patients that I know of who were really high risk, who had really what I thought might well have been COVID, I've asked them to get tested and they're all negative. So is there an expected time frame to know if we are successful in phase 1 and can move to phase 2? So the federal plan was no less than 14 days. The Oregon plan is 21 days, and how we picked the 21 days was kind of a compromise. But you typically would wait 2 incubation periods, which is 28 days to make any decisions. I think the 21 days was picked as a compromise. So Sherry asks, what phase is the casino in? Well, the casino is sovereign, and they're not in any of the governor's phases. I do not know what's happening at the casino. Okay, so a couple of other things. The question came up last time about remdesivir. So remdesivir is this antiviral agent that may show some activity against COVID. What we've seen on this is there was a randomized study done across the country, and what they found was it didn't make a big difference in mortality, but did seem to decrease the length of stay from about 15 days to 11 days. And anybody would want to have 4 less days in the hospital. So I think it's a good thing, but it's not a home run. A home run would be the disease got all better. I think I call this a bunt single, and so we'll call it that. That remdesivir was distributed to the states. It has been distributed to Oregon. So if there are people who meet the criteria in Oregon, presumably they can now get remdesivir. The other question is that there was the Harvard COVID symptom tracking study, and they're asking for people to track their data on an app. More data, the better. That looks like it's going to be good data. So I'd encourage you to do that one. The other one is OHSU and NICANCER are doing this. They're doing 2 studies where they're collecting swabs on people and doing some randomized things. If you get, and it's by invitation, so if you get invited to do that, I'd strongly recommend that people do it. I don't see any downside to it, and I do see some upside, because when somebody asked before about random testing, it'd be really hard for us to randomize. They have a great randomization protocol, and I think that would be the kind of randomization study that I would be engaged in. So Shannon asks, are you confident that the negative antibody tests are true negative results? Well, it matters which test you use, right? So if you use the little like pregnancy ones, I don't think anybody's confident in those. And in fact, the FDA said, ooh, you got to show us better data or you have to stop selling them. And so I wouldn't trust many of those. But if you get it from one of the big labs, Mayo, Quest, or LabCorp, I think you can pretty much trust. Now, negative antibody tests can happen for a couple reasons. One is it misses the antibodies. That happens apparently 1 or 2% of the time. Or you may not have developed antibodies yet. So when they check people for antibodies at 10 or 11 days after the illness, they didn't find, they found a lot of people didn't have antibodies. If you wait 20 days or 25 days, your rate of getting antibodies is much more. And unless there's a real urgency to know, I'd encourage people to wait 30 days to get 30 days after the illness to get their antibody tests, so that if you get a negative result, it's probably negative. Now, no test is 100%, but this one's pretty close, in the high 90s. Now, that also brings me to the question about the Abbott test, which you heard about, which is only 48% positive. Again, I don't know what the numbers are, but when anybody suggested that these PCR tests have more than a 70% positive rate, I really didn't believe that. Because we know from the best studies that if you do a nasopharyngeal swab, that 70% is about the best you're going to do, just because of getting the data, just because of getting the virus, because the virus may not be there in high amounts in the back of your throat, in the front of your nose, or in your mouth. And that is one of the big troubles with these testing, because they do have so many false negatives. And we saw at the White House this woman who was negative one day and positive the next day, so they changed quickly. And it may have been that the one the day before was a false negative. So these tests are good if they're positive. They're not so great if they're negative. And I certainly would not have people make big and bad decisions based on a negative test. So for example, like I'm negative, I can go visit my mom. Don't do that, because the chances are that there's maybe anywhere between a 30 to 50% chance that it's a false negative, and then I can infect my mom. So positive tests are great for finding it. Negative tests are not great for ruling it out. So Jenna says, wouldn't it be beneficial to test huge numbers of people? I don't really know. I don't think so. I mean, let's say we could magically test 10,000 people in Douglas County tomorrow. We think we would find 3 or 4 positives out of the 10,000. How do we know that? Well, there's a calculation that you could figure what your rate is going to be given your number of diseases. And I think the most we would find would be 3 or 4. It's an uncomfortable test. It's $200 a test. That would be $2 million. And most of the people you'd find would be asymptomatic, because obviously we're already testing the symptomatic ones. So would it be worth doing that? And I don't know, when more of these tests come out, like the Corvallis study and other studies come out, we could do that. But we think far and away the best way to do this would be to test every symptomatic person at the very beginning of the symptoms. Because how many times in a year are you symptomatic? I'm asymptomatic, I think, 350 days of the year. So you'd have to test me 350 times rather than testing everybody on the 10 or 12 days of the year when they're symptomatic. And that's really where the goal is. And I think in the countries that have done it, they started out by testing every symptomatic person. Once they got the rate down to a very low rate, then they tested contacts of symptomatic people to get the rate down to 0. No place in the world has gotten the rate to 0 primarily by testing first asymptomatic people. So what phase would the college be in? So everybody's in phase 1 in the county. The colleges, though, are close to the fall. And I do not know what's going to happen with the college in the fall. Yeah, so Janet says, so exercising with a mask on cannot be healthy, so I'm told. How can gyms open since it includes heavy breathing? So exercising with a mask is an interesting thing. In fact, if you go to the sports store, they actually have these masks to wear where they have different valves in them so you can simulate breathing at high altitude, which is thought to be beneficial for training your lungs. So you definitely can exercise with a mask on. Now, what I'll tell you is most people would find it really uncomfortable to do so because you do have a lot of sweat. So with exercise, first we would encourage outdoor exercise, since outdoor exercise is not thought to be a risk with adequate social distancing. So go on a bike ride, go for a run, do exercise in the park with 10 feet of social distancing, and then you don't need to wear a mask. Inside gyms, again, we're going to really enforce social distancing. And so, yeah, with social distancing, that's the key, because it's going to be pretty hard to both wear a mask and exercise. So I think what you'll see in gyms, instead of the cardio room having, I spent a lot of time in the cardio room, instead of the cardio room at the Y having, 10 treadmills and 5 bikes and 13 ellipticals, I think you'll see like just a few of each, and so that each machine is 6 or 10 feet away. Okay, well, it's a nice Friday. Hopefully everybody is going out enjoying the nice weather, and so we'll see. I just had 2 more things I want to talk about. One is this pediatric disease. So this pediatric multisystem inflammatory disease is really, really, really a concern. And so what this seems to be is in places that have a lot of disease, a few weeks later, you start to see this disease in kids. So, the New York stuff peaked a few weeks ago, and now you're starting to see these diseases in kids. Similarly, Italy had this huge peak, and a few weeks later, you saw the peak in kids. And similarly, UK, big peak, a few weeks later, you saw the kids. Some of these kids have positive antibody tests, and some of the kids have positive direct tests. But when you look at the antibodies and antibody types they have, they've likely had the disease a few weeks before. So these kids had the disease, many of them were either asymptomatic or mildly symptomatic, and then 3 weeks later, they come up with this new thing with really high fevers, red eyes, a tongue that looks amazingly like a strawberry. So if you look at strawberry tongue from this disease, you say, wow, that looks like a strawberry. And they get this rash, they get really cranky, they get this fast heart rate, they get changes in their blood vessels in the heart. And this is really, really worrisome because there have been some deaths in these kids who are really sick. So this is similar to a disease that we've seen in the past called Kawasaki's disease, which has been a rare disease and we've not really known what causes it. But they have many of the same symptoms with the red eyes, the strawberry tongue, the heart things, the rash, the abdominal pain. And these kids are really, really sick, and some die. So it's a big worry. And I think that's another reason to say, oh, just let it burn through the population. Because if you let it burn through the population, you'll have a lot of this pediatric disease. And this is a miserable pediatric disease. So I think our current strategy, trying to contain the disease, try to decrease the number of infections overall, is the right way to go. So Dana says, do you think it will be a bad flu season this next winter because of COVID? Flu is so hard to predict. Flu is as hard to predict as sports, like to predict who's going to win the Super Bowl, who's going to be bad. I mean, you can usually predict that the Browns are going to be bad, but other than that, you really can't predict much about sports. And I think with flu, you can say we're definitely going to have a flu season. How good or how bad it's going to be, don't really know. Usually we would predict how bad the flu season is going to be around this time of the year when we see how it happened in the Southern Hemisphere. This year has been a funny year in the Southern Hemisphere because they've also had lockdowns in the countries we look at, which is Australia, New Zealand, and South Africa. And so it's a little hard to know what the flu season is going to be like. But what we do know is that when flu arrives, and flu arrives every year in the fall, is that it's going to make this really complicated because now when you have a temperature of 103 and shaking chills, do you have flu or do you have COVID or do you have both? And that's why we're really, 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 really going to push people to get a flu vaccine. We probably will not have a COVID vaccine, by October, but we almost certainly will have a flu vaccine. And if we can get enough people immunized for the flu, it's going to decrease the number of people who have the flu and decrease that confusion of, is this flu or is this COVID? So is the older population asymptomatic as often as younger people? We don't know about the senior population overall. What we do know is among the population on the Diamond Princess. Again, this is the ship. They had one infected person and about 800 infected people. They were quarantined in Yokohama, Japan. The Japanese very carefully did lots of testing, so they knew about those people. So of about the 800, about 40% were initially asymptomatic, about 40% mildly symptomatic, about 20% of the people sick enough to be in the hospital, and about 2% of them died. Of the 40% that were asymptomatic, some later developed funny symptoms, diarrhea, anosmia, a little bit of a cough, fatigue, but still not super duper sick. So when you look at those initial 40%, some of them went into the mildly symptomatic group. Very few of them went into the hospital group, and I'm not sure there were any that went to the hospital group. So yeah, older people can be asymptomatic. And it's funny that you would then in the senior population get that many people would be asymptomatic and then people would die. So the variability of this case presentation is just one of the most shocking things. There's no other disease that I know of that has this wide range from asymptomatic to a horrible death. It's really weird. I mean, for example, with measles, even the most mild kid with measles is still pretty sick. And then the sickest are really sick. So there's a range from pretty sick to really sick. But this one goes from all the way from asymptomatic to death. This is the weirdest disease. We're learning so much more about it. We're learning that you have all of these funny symptoms. The COVID toes, the COVID rashes, the terrible diarrhea, that loss of smell. All these things that are so unusual with the disease, and then the wide range of severity is bizarre, and the transmissibility of the situation that I could infect 52 people at choir practice is just stunning. When we talked about super spreaders for things like flu, we're talking about infecting 3 to 5 others. We're not in fact talking about infecting 52 people in 2.5 hours. So there's so much weird about this virus we don't know about, and there's something we're learning every day. So I love to read. So I've probably read 50 articles today about this, some of which I believed in, some of which I take with a grain of salt. But anyway, so we're staying on top of this. I think in Douglas County we're doing a good job. Even though we're in phase 1, please, if you can go get your hair done, want to get that done, do it. If you want to go to the gyms when they open up, and I think they're going to start opening up in June, go ahead and do it. I think if you want to go to your favorite restaurant and have a seat, do it. But still, maintain social distance. Stay home if you're sick. If you can telecommute, please telecommute. Wear face coverings out in public. And again, the reason you're wearing the face coverings is not so much to prevent me from getting the illness, but is to prevent me, if I'm in that pre-symptomatic phase, from giving it to you. I think with that, I think we've got it. Everybody should enjoy this great weekend. I'll be back on Monday. If you have questions among that time, let me know, and we'll take care of it. Again, Bob Dannenhoffer, Public Health Officer from Douglas County. Thanks.